anyone, luckily yesterday there was a good talk on DOHAD, Developmental Origins of Health and Disease. Is everyone familiar with that concept? It's big in medicine, but not so much in dentistry, and I'm hopefully going to try to convince you that it should be. Okay. It's not moving. Not advancing. Hey, start my clock over again. Do I have to do that every time? Okay. It is what it is. Maybe it's off. Anyway, the DOHAD hypothesis, am I close enough? The DOHAD hypothesis is predicated on an English physician in the 60s, made some observations in, I think, Wales or southern England, a poor area in the early 1900s of kids that were born with a low birth weight. A midwife kept excellent records, and he found that was getting metabolic syndrome in the 5th decade of life, and they weren't affluent people, and something didn't make sense, so he made up this theory that something to do with being well fed, but you're starved in utero, can set you up for disease in later decades. And he got support from the Dutch famine of World War II. The Nazis starved out much of the Netherlands at the end of World War II when they knew they were losing. And their resistance was so fierce that the only way they could stop them, the Nazis, was by starving them. And what Barker did to support his hypothesis was to look at the records of the babies that were in utero at the time of the Dutch hunger. And sure enough, in the 5th and 6th decades of life, they all showed signs of metabolic syndrome and actually schizophrenia. So I'm going to develop this later for my field of dentistry. How are we doing here? Sorry about that. Okay, for sound.
It's often thought of as cute. So parents put the videos on YouTube. They're tiny children snoring. But today's study raises the question, could a pattern of noisy nights be linked to behavioral problems down the road, like attention deficit disorder, hyperactivity? And could any of it be prevented with a good night's sleep?
Snoring is actually a red flag. It is a hallmark for problem breathing at night.
Today's study followed more than 11,000 children for 7 years. Those who snored, breathed through their mouths, or had apnea, long pauses between breaths, were up to twice as likely to develop behavioral problems by age 7.
So that's a huge sample size. The Avon study in England, 14,000 kids over 8 years, unequivocal link between intermittent hypoxia during early childhood and later neurobehavioral problems. This has since been verified by many other studies, so it's unequivocal. Name of my talk is Pre- and Post-natal Retrognathia. That just means backward jaws. Serious health problems. It's not just unattractive, but it can lead to all kinds of health problems, not just temporomandibular joint disorder. I also call this chinlessness, yet another health problem associated with industrialization. I not only lecture about chinlessness, I am chinless. I'm strikingly handsome, right? But luckily I don't walk around sideways, and I do have severe apnea, and I'm not overweight. So anyway, this is my airway, and that's really the point of this whole talk. When you see an adult with a retrognathic mandible, backward lower jaw, it first could have been picked up, detected, and rectified at about age 2 or 3. Okay, and I will make that argument and give evidence for it. This is the talk I gave 3 years ago in Atlanta. Unfortunately, the YouTube intent that they had for all of our talks didn't work. Only 6 or 7 made it, and mine wasn't one of them. But at the time, I didn't really understand the mechanism behind this, and I'm now doing postdoc research at University of Pennsylvania in anthropology and orthodontics. And we came upon something startling that I thought I had to scrap my whole theory, and instead it's ended up becoming much more strong evidence to support what I talked about at in Atlanta in 2013. And this was the abstract for it. Proposed that ancestral type infant feeding and weaning is essential for development of the jaws, teeth, and face. That's been talked about in a couple other talks here today. So anyway, when you see kids falling asleep in school, they're completely exhausted. They're not just tired. And giving them speed, amphetamines, Adderall, Ritalin, it's really not what they need. And in fact, it screws up the cause of their problems, which is sleep deficit, sleep deprivation. Before they get exhausted, they try to stay awake, and they're very difficult to manage. So we're actually we get referrals from kids whose parents do not want to put them on Adderall and have heard about our treatment actually mitigating some of the symptoms that are erroneously called ADD. And just by giving them a better ability to breathe through their nose can really make a difference in a kid's life, especially if you get it really early. We're treating kids as young as 2.5. Anyway, Karen Bonnick was the author of the Avon study report that you saw in the opening slide, and she's now very interested in our proposal that she look at malocclusion as possibly being an antecedent to risk for sleep disorder, for attention deficit disorder. So we're working on a protocol to do a multi-centered effort on this. The apnea in children also puts them at risk for type 2 diabetes and for heart disease, for hypertension, sound familiar, metabolic syndrome, and according to David Gozal at the University of Chicago, who's a sleep medicine physician there, cancer, some cancers. So the shape of the jaw, the craniofacial mandibular architecture, hypothetically could predict risk for a lot of problems. And again, I'm going to make an argument over the next 40 or 35 minutes. What is common to a lot of children and adults that have sleep and breathing disorders is a retrognathic or retrusive chin. They call that class 2 malocclusion. These are the three main forms of malocclusion that were developed by a guy named Edward Hardley Angle in the early 1900s, late 1800s. The most common is the one in the middle, class 2. Most class 1s actually are class 2 as well, but the system of classification was developed in the 50s, mainly by one or two white guys who thought this is what everybody should look like. Most everybody in industrialized cultures in the 1950s were at least slightly retrognathic, so that became the norm. So a lot of diagnoses are being made erroneously, and we're proposing to change the classification system to reflect a genomic or an anthropologic reality, and I'll show some data from some of our studies that we're doing on that. Okay, we're doing this again. Okay, so Western diseases, lifestyle diseases, diseases of civilization, we think skeletal malocclusion should be there as well, class 2. You can see the superimposition of the chin profile. If that is a woman of childbearing age, do you know that that is a risk factor itself for her having not only pregnancy complications that impair her own health, but very, very strongly correlated with risk for preterm delivery and most of all, intrauterine growth restriction. And I will show you titles from several papers. I don't have time to go through them all, but this has been in the OB-GYN literature for at least a decade and is only now coming to light. Class 2 malocclusion is first evident in the primary dentition and perhaps even before. This is in the peer-reviewed orthodontic literature. If it it's first detected under the age of 5, it always persists and it always gets worse unless there's intervention. But most orthodontic protocols don't start seeing kids till maybe 9, 10, 11. That is medically indefensible in light of what I'm going to show you, and that is going to change. This is, again, from the early 1900s. The class 2 malocclusion is first detectable in early childhood, in infancy. Lots and lots of literature on this that doesn't get taught in dental school. Ask me how I know. When I first learned of this, I was angry. And That's why I put myself back in school. I'm 61 years old and halfway to a bachelor's degree in evolutionary biology. As I said, I'm doing postdoc research at Penn now, so I'm scrapping the bachelor's. We have data to suggest that this can first be detected in a mid-gestational ultrasound. And we are developing a metric by which we can compare what we see in mid-gestation to what we see postnatally. This is that kid now. He was one of my patients. Mom brought him in. I've been following him, and now she's putting him in treatment because he's starting to show some signs of breathing problems. So anyway, again, class 2 correction improves nocturnal breathing in adolescents. If it improves it in adolescents, it improves it in children. It can improve it in senior citizens. Okay, so this is something that can't be ignored. If you watch that graphic on the side again, you can see where this orthotropic treatment is designed to get the maxilla, the upper jaw, forward first so you can bring the lower jaw forward. Now, if you bring both jaws forward, you're bringing all of the tissue, the soft palate, the tongue, all of that comes off the back of the airway. And when a child sleeps supine, that can block the airway. So what we're trying to do is give the best architecture to the most amount of children at the earliest possible age. That's our mantra. Again, this is also considered an adjunctive or even an alternative to TNA surgery. The scourge of pediatric otolaryngology is recurrent apnea post-TNA surgery. Over 50% of kids will show some sort of sleep breathing disorder after they get their tonsils and adenoids out. So we're suggesting to ENTs not that we substitute their surgery, but we do it with them so that the kid has better architecture and may have a better chance. And we're doing a retrospective trial at Lurie Children's Hospital in Chicago of several children we've treated, some who have had adenoidectomies and some haven't, but almost all of them have had sleep studies, polysomnograms overnight that we can compare. So again, like I said, the American Association of Orthodontics pretty much in their brochure says that they want to see kids by 7, but usually they're not treated until about 9 and 14. Again, medically indefensible when they become aware of this data, and they're not, so they're not liable yet. This is in the literature, 75% of children 6 to 11, and it's really earlier than that, but that's not reported in these studies, have an 89% from 12 to 17 have malocclusion, most of which is retrognathia. Malocclusion is not seen in non-Western exposed cultures, whether it's before the Industrial Revolution or somebody talked about the Hazda. There's one last hunter-gatherer tribe yet that's non-Western exposed. There used to be lots. There's still lots of ethnographic data that can be analyzed about the craniofacial morphology of these people. When does this first show up in this teenager? Maybe there? How about in utero? I'm going to make a case for that. The first large-scale evidence of tooth decay, anybody know when it first happened, entered the human condition? There you go. Agricultural revolution. Again, when I heard this from Philip Pujol, an epidemiologist in the dental school at University of Washington in Seattle in 2008, I was pissed. Like, why didn't I learn this in dental school? In fact, I doubted him. I didn't have the capacity to Google him, but when I found this out, I really was not happy, but I turned it into what I'm doing now is pursuing, a degree in this. Anyway, first large-scale evidence of tooth decay, we go, anatomically modern for 250,000 years, all that time with no decay. And then we get something else happening, the Industrial Revolution, and that's when we start to get malocclusion, retrognathia, crowding, and associated problems, breathing problems, which aren't well documented before the Industrial Revolution, but given the smoky air, retrognathia, we can speculate that that's probably when sleep apnea and associated illnesses started to occur. So phylogenetically, this enters the human condition probably 250 to 300 years ago. I have references for all that if anybody wants them. Again, my talk, it'll be on YouTube, I guess. I didn't download it before, so you won't be able to get it, or I'll leave it for anybody. But why did it happen? And again, that is the gist of our research that we're doing at Penn, and I'm going to give some reasons as to why we think that was a point of departure from no malocclusion in anatomically modern humans. So is maxillomandibular retrusion. Now again, we're focusing more on the mandible, but if the mandible's back, so is the maxilla. There's very seldom where a mandible is way back and the maxilla is normal. But this is utilizing anthropologic norms, not the norms that orthodontists were trained to use. But we're finding in these prehistoric, pre-industrial skulls that they're prognathic. We've got them from all stages of gestation. Stillbirth was and infant mortality was a big problem before the industrial, even up until about the 1900s. So we have access to many crania that we can analyze that were non-Western exposed, the mothers, while the child was in utero, and they are all maxillomandibular prognathic. So that's what I thought blew my theory all to hell. I thought, oh my God, these kids are born, looks like I got in there and treated them in utero. And it's sort of like, what's going on here? But you'll see my explanation. And I think it'll make sense a lot to this audience. This is what we're taught. This is in lactation consultants' books, that all babies are born with some degree of retrognathia. Well, all babies, what is their sample? Modern babies, Western exposed babies. They're teaching this in school. This is from that same book. This is from the leading orthodontic textbooks. Facial profile changes with age are evident when looking at a newborn baby with a convex profile. That just means that it's convex, meaning it goes in to the chin like that. Retrognathic and retrognathic mandible, the lack of a prominent mandible facilitates passage through the birth canal and subsequent feeding. Bullshit. It's not true. It's supported nowhere. Dr. Prophet is a brilliant man, but there is no reference given for this, and it is assumed. I learned this in dental school. But if why do we get sick? And again, I'm adapting the whole concept of evolutionary medicine to oral medicine. The ground zero for this is at the University of Pennsylvania. But there's absolutely nothing in the literature. The birth dilemma, our brains got bigger, and as we walked upright, the pelvic girdle got smaller. And how in the world? Oh, the chin coming back. That must help. I mean, the fontanelles all fold over each other. That's true. The mandible goes nowhere near the pelvis. Nowhere. It does not. You look at any video of a baby exiting the birth canal, the chin goes nowhere near it. It's total nonsense. Retrognathia is not the normal human phenotype. Okay, so I participated in a focus group that was National Science Foundation sponsored at Duke in 2012. Anthropologists and dentists got together to try to figure out how we could come up with cross-disciplinary activities that anthropologists could understand how their work applied to medicine and dentistry, and that we dentists could go into anthropology schools and teach them dentistry. So far, I've been asked to lecture all over the world because of this, in anthropology departments and dental schools. This is one of the observations that's been made, and anthropologists have known about this for decades, that jaws have been getting smaller, but allometrically, I mean, they scale. The jaws have gotten smaller, but the wisdom teeth still fit, okay? Dental crowding doesn't start till you have non-allometric shrinking, and that's more of an epigenetic short-term phenomenon. So what they mean is by smaller, they mean less prognathic and narrower this way. Daniel Lieberman at Harvard has done a lot of work on this, and he feels it's the modern diet. So that was sort of one of my inspirations to pursue my own thesis, which is early infancy and early childhood feeding and weaning. So anyway, the mismatch hypothesis, a mismatched human genome, it has designed a mascatory respiratory apparatus that share one common orifice, the mouth. Chewing, breathing, swallowing, tongue posture. There's lots of things that go into this that explain why there's a mismatch in a modern environment to an anciently derived genome for the mascatory and respiratory and speech apparatus. There's actually 3 survival mechanisms there. We first focus on when women started to leave the home from agrarian sustenance, and then went into cottage industry, you can see that the woman could still stay in the home and she could make cloth and the merchants would come and pick them up. And that's actually a woman in the Industrial Revolution who's breastfeeding. But when women left the home and went into the textile mills and into the coal mines, that's when they first had to give up breastfeeding. Well, it's more than breastfeeding. They had to give up what we call ancestral patterns of weaning, baby-led weaning, chewing hard foods for 3 years. That's the norm. We know that from isotopic evidence to show that over the course of anatomically modern human history over 200,000 years is that 3 to 3.5 years of on-demand feeding and weaning was the norm for humans. There's a reason for that. Another thing, I did a master's degree in human nutrition before I went into dental school. I never learned that oxygen is a nutrient. You know, we think of vitamins and minerals, macronutrients, trace elements, phytochemicals, but we don't learn about oxygen, even water sometimes. They don't call it a nutrient. And they do not teach us, and they're still not teaching dietitians, about the mechanical aspect of nutritional processing. Is that there's so much to nutrition of how we acquire substrates from our environment and how we need to process them ourselves with our masticatory apparatus, which is also the speech and breathing apparatus. This is what we found looking at skulls from all over the world, from all eras of time before the Industrial Revolution, that the front of the face is ahead of a constructed line. Frankfurt horizontal is a horizontal line. End perpendicular is the one that extends down from where the frontal bone, forehead bone, and nose meet. And the point right underneath your nose is always ahead of that line, virtually 100% of the time in every skull. And this is thousands of cranial skulls from all over the world that we've looked at. We found maybe 1 or 2 that are right on the line, but never behind the line. So that suggests prognathic mandible, prognathic maxilla. Again, I could show hundreds of these skulls. No time. You'll have to take my word, and I can, justify this with anybody if you need studies and references. This is what we found from pre-industrial fetal skulls that they're forward. You saw that. We're taking 3-dimensional CAT scans on these now, and we're measuring landmarks. Again, we're doing this in hopes of developing a new database that now clinically practicing orthodontists and other dentists who do orthodontics. I'm not an orthodontist, I'm a pediatric dentist, but I do almost exclusively airway-focused orthodontics. Most of my patients are under 6. We have one of the most largest practices in Chicago. We fill almost no tooth decay because we don't have it. I'm a sugared Nazi. And if I can do it, any dental practice can do it. And we focus completely on airway orthodontics, my partner and I, Dr. Janet Panarella. My other research partner at Penn, Mariana Evans, is an orthodontist and doing the postdoc with me in the museum. She also is one of the biggest practices in the world, treating kids under the age of 6 with airway orthodontics. Lots of speculation about where malocclusion comes from. And one thing we know for sure is that when hunter-gatherers become more industrialized, their jaws become narrower in this dimension, they become longer, and they become more retrognathic across the board. So the goal is to get this back to what their genomic potential is, and it has to be recognized very early. Therefore, that's why we want obstetricians to be, we want to give them this metric to measure this angle. It's called the inferior facial angle. If it's less than 70 degrees, we're finding preliminary. It correlates with a risk for sleep disorder breathing. If it's less than the 5th percentile, they say it's at risk for a syndrome. And if it's not at risk for syndrome, they say they're normal. So they're calling kids in the 9th percentile as normal, and their chins are way back. So we're hopefully going to change the culture a little bit. I'm going real fast because I just really want to get through this, and I want to get to some questions. How much? I got 5 minutes. Oh, my God. Well, anyway, this is on cheers. These are things that we can absolutely see. Obtuse nasolabial angle. That's the nose and the lip. Retrusive chin, open mouth. And then Carla is seen in the next.
Paula, why don't you take out an ad in the paper? You never
That's
really know what
Nick.
the
He
kid's
wants
gonna look
he wants one of his own kids back because his new wife can't have kids.
Law. I have no choice but to do what I'm trying to avoid at all costs.
What, breathe through your nose?
No.
So did you hear that,
I'm taking
Carla?
you to
I'm going to
court.
do what I want, trying to avoid all my life at all costs. What? Breathe through your nose. So it's funny, but it's not. You know, he's probably going to die sooner than later. Anyway, DOHAD, I won't talk about. It was already discussed, and I brought it up a little bit. Epigenetics. Robert Feynman, the physicist, if you think you know about quantum physics, you probably don't. People who think they understand it. Epigenetics is kind of like that. The first paragraph, John, you have ruined me for other men. I yearn for you. I feel nothing but heartache when we are apart. I am so happy. And the phenotype is John is happy. He's smiling. But, John, you have ruined me. For other men I yearn. For you I feel nothing but heartache. When we are apart, I am so happy. That's going to change his phenotype. He's not happy, right? But all we did was change the punctuation. That's not a mutation. We did not change DNA sequence. Okay, so I developed this with an evolutionary geneticist, and just as a simple way to teach about epigenetics is that a gene can start out can go one way or the other, disease or non-disease, and depending on the environment, it shifts it one way or the other. Well, we're talking about healthy phenotype versus disease phenotype, healthy expression versus disease expression, and we're calling dental malocclusion as a disease expression, is that the genomic potential is that prognathic with all 32 teeth fitting, okay? The DOHAD hypothesis doesn't always work, and Barker found that there's a lot of cultures that were exposed to famine in utero, but they didn't experience the problems in the 5th and 6th decades of life because they weren't overfed when they entered the world. The placenta programmed the baby. You're about to be born into starvation, and it'll be that way all your life, which is probably the way it was in the Pleistocene. But what happened in a lot of these modern-day famines is they still starved, but not as badly, and they still lived a long life. So it doesn't always hold. After the Dutch hunger, what happened? The Allies dropped all kinds of fatty foods and carbohydrate-rich foods, and that's why all these people got sick in the 5th, 6th decade of life. I looked up DOHAD in dentistry and found out that enamel hypoplasia correlates well with the risk for dying early. So that's the only thing I could find. I wanted to develop this for dentistry. So what I have done, and I'm going to go 5 minutes into mine because I have to get this across, is that I substitute oxygen as a limiting substrate, that if a mom snores or smokes, they give birth to smaller babies. We know that. Well, I'm suggesting that what's happening is the placenta is programming the fetus to say, look, you're about to be born on Mount Everest, okay? Low oxygen tension. It behooves you to be short. Mountain dwellers are short, and it's because the musculoskeletal demand, the highest reservoir of mitochondria, is less. So they develop normal lungs, they get thicker blood, and they have less O2 demand. So women who have apnea, women who smoke, they absolutely give birth to smaller babies. And this is borne out in the cultural anthropology literature that mountain dwellers absolutely are smaller. And high altitude is a laboratory. It's a natural laboratory. We've studied all kinds of mountain dwelling people. They are short, but they live fairly normally. They have normal jaws too. I'm going to go somewhere with that if I have time. So anyway, we know that there's something going on epigenetically in terms of what is being conveyed to the placenta about what the environment's going to be like when you get out. Intrauterine growth restriction, the one on the right, on your right, that is a smaller uterus, and the one on the left, and you can see it's like a studio apartment instead of a big townhouse that the baby can grow in. They're shorter. Everyone pays attention to their long bones, but guess what else is a bone? The face and the mandible. Nobody's talking about craniofacial growth. This was an article I found, Mount Everest in utero. It's from a 19th century physiologist who said that just like the mother by the flight attendant is told to put the mask on yourself or the parent and then fix your kid, the O2 that a mother gets while she's pregnant, she has the highest demand for it. And so babies have learned throughout evolutionary history, mammalian history, from when we first were in a low O2 environment to evolve inside, develop in utero in a low O2 environment. So this is, you depleted a little bit by smoking or apnea, you're going to make that kid crash. You can kill a kid by snoring, not innocent snoring, but having severe apnea, overweight. This is something that's not talked in pregnancy wellness protocols. They talk about, vitamins, pregnancy vitamins, and don't eat fish with mercury. That's good. Exercise, do yoga. But nobody's talking about respiratory wellness. This has got to enter into the conversation. These are just several papers that show the craniofacial complex is affected by intrauterine growth restriction. Obstructive apnea and pregnancy is associated with small jaw, short stature. There's all kinds of literature on this. A paper came out last week. They labeled it. There's a name for intrauterine hyperglycemia. They call it pregnancy diabetes, right? Gestational diabetes. Preeclampsia for gestational hypertension. Why not gestational apnea for women who have apnea? They're starving their fetus of oxygen who's already thriving in a hypoxic environment. Several studies. Again, I just want to get through some of my data so I can get to some questions. The studies show that the one on your far right, those are severe retrognathic babies beneath the 5th percentile for this inferior facial angle. If they're above that, they call them normal. That kid to the left, that chin is way back. It's not risk for a syndrome like Pierre-Robin syndrome, Treacher-Collins, Crouzon's, cleft palate, but it is risk for morbidity called sleep apnea, early pediatric apnea. So we've, again, measured several skulls. I've taken patients from my own patient base and asked mothers for their ultrasounds, and you can see there's a definite correlation. Now, we've only looked at about 30 or 40 of these, but there tends to be this correlation of an IFA of less than 70 degrees correlates with retrognathia in the postnatal period. We're very early on this, but we've gotten some academic obstetricians very interested in this. I feel that it is catch-up growth, lack of catch-up growth. The reason, and I stress, here's what happens when babies, when they're babies, if they're born short, even not real short, they have opportunities for catch-up growth because they get good food, but the mechanical stimulation to the long bones is what helps them overcome and catch up in their own growth. Well, nothing like that happens in the mouth because babies are eating Gerber and babies are drinking bottles. They're not breastfeeding and they're not baby-led weaning. So that is the gist of my whole theory, and that's really what I want everyone to take home, is that pregnancy wellness needs to be addressed by all people who have exposure to women of childbearing age, whether they're pregnant or not just nutrition and activity, that's important, but respiratory wellness, and the need for catch-up growth, not only in all the long bones, but the craniofacial complex. It's another thing to justify how mothers can benefit their babies, not making them feel guilty, but even if you can't breastfeed, use a cup. Don't use a bottle. Babies can use cups. There's studies that high-risk preemies in the NICU, you can cup feed them and they get enough sustenance. This is one of the things.
Revealed how babies breastfeed. It was previously thought that babies use a compression motion of the nipple to push milk out. But the new images show that babies extract milk by lowering their tongue to create a vacuum. The ability to produce a strong vacuum may explain.
So you can see there.
Have revealed how.
Well, the nipple is being pushed against the front of the jaw, the front of the face. There's a suture here called the incisive suture that dentists don't get taught about. They teach us that it's closed at birth. It's not. We're finding in these museum specimens that it's patent until teenage and even young adulthood, is that can be pushed forward and cause the prognathic maxilla and room for the tongue to be off the airway. So they're like fontanelles, the soft spots on the head. They're all over the mouth. In babies, it's so malleable that you can, with ancestral type feeding and weaning and other things, besides feeding and weaning, can help grow it. Lack of tongue tie, relieving tongue ties in babies, papoosing is what our, not suggesting we papoose like this, but some people do. Look at how the baby has to hold his chin up. That mother right there, she was born that way out in the fields. Okay, this is click speaking of the Khoisan. They're African people. If they don't learn how to communicate, those are consonants that they're forming. If they don't learn how to communicate in early childhood, it can impair their ability to survive. I'm just going to blast through and try to get some questions. These are just data from our sample comparing. These are pre-industrial fetal skulls, all forward. So sorry to buzz like this. We have a team. We can get x-rays on 2-year-olds. This is a kid whose airway you can see. That's the airway before. That's after. By 3, all the ADD, all the symptoms went away. Mom is actually a dental hygienist. And that's it. If that woman is pregnant, that could be a problem for her fetus. So that's it. Any questions?
We didn't come in the beginning. I don't know if you covered it. What are you actually doing physically to change the facial structure?
We're using retainers. They look like standard orthodontic retainers, but again, they're almost the size of a dime. They're very tiny and they snap in the mouth. And these kids sleep in a little, it looks like a catcher's mask that hooks up to that. And while the kid sleeps, it helps the upper jaw grow forward. And if you get them early enough, the lower jaw will start to translate forward as well. Otherwise, we put them into functional implants, which helps them bite forward and the lower jaw catches up to the upper jaw. And it can happen within 8-10 months. You start to see
Is that similar, but used in a different way of people that I know who are widening the dental arch so that the kids don't have that narrow dental arch?
Yes, widening is only part of it. They have to be brought forward most of the time too.
Does that work on adults?
Yes, but not as well. And surgically, we actually do, we surgically do it on some kids, but you know, we show surgical cases that this adult could have avoided this if we would have known them when they were 3, you know, get the time machine. But yeah, expansion this way is a good way, but early, before the age of 5 is really when it has to start, pretty much all the time. You'd never tell a parent, your kid has high blood sugar at 4, save up your money for an insulin pump. But it happens all the time. Save up your money for braces. You hear it all the time. That's medically indefensible in light of this knowledge.
And then the second thing to that bit was, so it's not just nutrition you're saying, it's
yes.
how they're eating and
yes.
the breastfeeding
Physical
all together.
Stress. Physical stress.
Physical
exactly.
stress. Okay,
Thank you.
Thank you.
Stefan, so glad you're here.
Hey, Kevin. Yeah, it's my pleasure. I think this stuff is really interesting and important. So let's assume that this is true, that there's a in utero difference between ancestral jaw development in utero and modern jaw development. So, I mean, do you think it's possible to, I mean, obviously in the time of our ancestors, they didn't have retainers and things like that. They didn't have orthodontic treatment. So, I mean, do you think it's possible to use ancestral type interventions to catch up?
Yes.
Postnatally? And if so, then what do you think is the best evidence for what we should be doing?
Well, one of the speculations we say is that some sort of intermittent hypoxia, it may not be apnea, but just limiting a little bit can impact, and people aren't noticing it, that there's no opportunity for catch-up growth of the mandible. So we're saying pre-industrial ancestors, most of them had huge airways. And even though these mothers were sick, I mean, these kids were still born for a reason. They still were born with forward jaws, and we think it's because the moms had good airways. If nothing else, they had great airways. The things that we're saying is do all we can to encourage mothers to have good respiratory health while they're, in addition to nutrition and physical activity. Don't ignore the respiratory health of the mother during gestation. And these devices that we're using, they're not really brute force. All they're doing is gently, these malleable tissues are making room for the tongue, which is a muscle. Whenever there's a conflict between muscle and bone always yields. You get that tongue moving up against those palatal fontanelles early in life, they're gonna develop. Every fetal palate we've looked at, they're wide and huge, even the stillborn ones. So I don't know, does that answer your question? Breastfeeding, encourage breastfeeding, baby-led weaning. Those are, what's that?
I said we'll talk more after.
Good,
don't
like
have
last
makeup
time.
all the time,
I
yeah.
saw him in Atlanta.